This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon. Thank you for joining us for our first HealthyU webinar series. Today we have Dr. Aitzaz Ahmed joining us today. Dr. Ahmed has been a practicing rheumatologist for 25 years. He is certified by the American Boards of Internal Medicine and Rheumatology and is a member of the American College of Physicians and the American College of Rheumatology. His clinical focus includes the diagnosis and management of autoimmune and inflammatory disorders, non-surgical treatment of joint pain, and the management of osteoporosis. He also enjoys graduate medical education and teaching students and medical residents. I ask that you please enter any questions that you may have in the Q&A feature at the bottom of your screen. And once Dr. Ahmed has completed his presentation, we will answer your questions. I'd now like to hand it over to Dr. Ahmed.
Good morning, and thank you for the introduction, Christine. It's a great pleasure for me to be here delivering this webinar about osteoarthritis, and the purpose of this talk is to provide participants with information about the prevalence of osteoarthritis, which is the most common type of arthritis, information about what causes osteoarthritis, how is it diagnosed, and what treatment options are available for patients. And let's advance to the next slide, please. So osteoarthritis is a very common condition. About 46 million people in the United States, 10 to 12% of the adult population have this disease. The most recent data from 2010 indicates that 2.2% of patients throughout the world who have disability have it due to osteoarthritis. And 10% of patients who have disability caused by rheumatologic or musculoskeletal disorders have osteoarthritis. Osteoarthritis is a very rapidly growing health condition as the population ages. It accounts for 17 million patients per year living with disability according to data from 2010. And the prevalence has increased quite a bit. There's a 64% increase compared to the previous 10-year period from 1990 to 2010. It has a huge economic impact and high costs related to healthcare. These costs involve loss of participation in work, lost productivity, sick leave, premature retirement, and of course the impact of pain and disability on the daily quality of life of patients. In order to understand osteoarthritis, it helps to have some familiarity with the anatomy of a joint. A joint is a structure that joins bones together to allow movement to occur. So here is a schematic representation of an ideal joint. You see the two bones that form part of the joint. The bones are connected externally by fibrous tissue, which is called a joint capsule. Inside the fibrous tissue, there is a very thin lining of a membrane, which is called a synovial membrane. This membrane contains cells, which are called fibrocytes and synoviocytes. These cells are involved in production of lubricant fluid in the joint, which is called synovial fluid, and also in transfer of nutrients into the joints and transfer out of the joints of metabolic breakdown products. The ends of the bones are lined with a semi-transparent, rigid yet flexible tissue, which is called cartilage. Cartilage provides cushioning between the ends of the bones and helps the bones glide against each other to allow for movement to occur. So why do people develop osteoarthritis? A simple way to understand it is that osteoarthritis is the result of mechanical stresses acting on joints. Now, that's a normal daily occurrence in life. That's the purpose of the joints, to withstand mechanical stresses. Why is it that some people go on to develop osteoarthritis and others don't? Well, the answer may lie in some susceptibility factors that increase the risk of a person developing osteoarthritis. These factors might include genetic factors, because having a family history of osteoarthritis increases the risk of a person developing the disease. Advancing age, because it correlates with more wear and tear in the joints. Ethnic background, for example, hip osteoarthritis is more common in the US as compared to China. Nutritional factors play a role in increasing the risk of osteoarthritis, particularly overweight and obesity. And there may be a gender difference in the rates of osteoarthritis. So particularly osteoarthritis of the hands and knees seems to be more common amongst females. And so it's thought that this combination of repetitive joint stress and having risk factors present leads to progressive loss of the cartilage, the cushioning between the bones, remodeling as the bones try to repair themselves, formation of osteophytes, which means bone spurs, leading to low-grade inflammation in the lining of the joint. This slide illustrates the progression of osteoarthritis. So on the extreme left is the first stage of osteoarthritis. A patient at this stage might be experiencing some symptoms. However, there's minimal disruption of the cartilage. There is some 10% loss in the joint space, followed by stage 2, where the joint space is further narrowed. At this stage, microscopic cracks appear in the cartilage. These are called cartilage fissures. And as a reaction to the stress, the mechanical stress, the bones try to repair themselves, which starts to form osteophytes or bone spurs. In the third stage of osteoarthritis, the joint space is reduced moderately. The gaps in the cartilage can widen and they can expand till the underlying bone is exposed, which leads to the final stage 4 of osteoarthritis, where more than half the cartilage has been lost and damaged, and the bones are in contact with each other. So how do rheumatologists and general doctors diagnose osteoarthritis? Well, it's mostly what's called a clinical diagnosis, which means that we listen to the symptoms that the patient has, and then we examine the joints to come to a conclusion. The major symptom of osteoarthritis is, of course, pain in the joints. The pain is typically made worse with activity and use of the joint, and it's relieved by rest. Stiffness is a common symptom that patients describe when they have osteoarthritis. Typically, it's difficult for a patient with osteoarthritis to start moving freely in the morning. And as the patients move, the stiffness improves. With osteoarthritis, the stiffness typically lasts for less than 45 minutes in the morning. Some patients also describe what's called a gelling phenomenon. So if they have been in one position for a while, let's say driving in a car for a long period, they experience stiffness again and difficulty moving from the position that they were in. The loss of cartilage can lead to a loss of function of the joint, so that people can experience symptoms such as decreased hand grip, difficulty buttoning up their shirt, or turning faucets on and off. Sometimes due to weakening of the ligaments in the joint, there can be instability, so a knee might suddenly give out or lock up as a person is walking. And when the joints are examined, we often find bony swelling, which is due to the bone spurs that form in reaction to loss of the cartilage. We find that the joints may be tender, they may be becoming deformed. And as a natural reparative process, the body tries to produce extra synovial fluid to increase the lubrication between the bones, so the joints may become swollen. X-rays are often ordered when we suspect a patient as having osteoarthritis and may be helpful in the diagnosis. And sometimes blood tests are ordered. There is no blood test for osteoarthritis as such. The reason we order labs are to rule out other conditions that can mimic osteoarthritis, for example, inflammatory conditions such as rheumatoid, arthritis, and gout. And here's a picture of a patient who has osteoarthritis of the hands. You can see that the middle joints and the fingers appear quite swollen. If we were able to feel these joints, we would appreciate some hard bony swelling. There are some other joints in the fingers closer to the fingertip. Those are also swollen. There's bony swelling of those joints. This type of bony swelling is called a Haberdin's node. And if you look at the thumb joint at the base of the thumb of the right hand, you can see that it sort of forms a squarish angle. And that finding is called squaring of the first CMC or carpo-metacarpal phalangeal joint. So just by looking at the joints, it is often possible to diagnose a person as having osteoarthritis. And this is an illustration of X-rays of the knee joint, comparing a normal knee joint on the left, where the blue arrows point to a transparent space between the femur, which is the thigh bone, and the top of the tibia, which is the shin bone. So joint cartilage is transparent on X-rays, and therefore it shows up as this nice dark space. The bones are quite visibly separated, which is as it should be. There's a lot of normal cushioning between the joints, so that's a normal knee joint. On the other hand, the section on the right shows a knee joint that has advanced osteoarthritis. As you can see, that nice transparent cartilage space on the left is completely obliterated. The bones are touching each other, so this is called a bone-on-bone appearance of the knee joint. Because the cartilage has worn out and the bone has to take the stress of walking and routine daily activities, the underlying bone becomes a little thickened. It appears whiter than the bone on the left. The technical term for this is subchondral sclerosis, but all it means is a thickened underlying bone. And next to the femur in the top left-hand corner, you can see a little calcification and some densities. Those are called osteophytes or bone spurs. So this X-ray is diagnostic of somebody who has very advanced osteoarthritis of the knee joint. So how is osteoarthritis treated? There are two components, and to me, a major or more important component is non-pharmacologic treatment, which means treatment that does not involve taking medications. And part of the treatment is physical therapy. Physical therapists are often very helpful, particularly for frail or elderly patients. They can show us exercises to strengthen the joints. They can improve our balance in walking. They can also evaluate people for orthotics or canes and shoe inserts, etc. They can apply modalities such as ultrasound and heat treatments. Of course, the benefit of physical therapy lasts only as long as it's conducted. And therefore, it's important for patients after they have completed their physical therapy to carry on the exercise at home. Nutrition plays an important role in the management of osteoarthritis. And patients often ask, what's a healthy diet or what's a good diet for osteoarthritis? And the easy way to remember a good diet is anything that's good for cholesterol and inflammation is good for osteoarthritis. So it means incorporating a lot of fresh fruits and vegetables into the diet, having a balanced amount of protein intake, and particularly focusing on carbohydrates. Choosing whole grains is better than refined carbohydrates. So things like white bread, for example, are not good for people with osteoarthritis, but whole grain bread might be better. And then regular exercise not only treats the symptoms of osteoarthritis, but it also acts as a preventive against people developing osteoarthritis. The exercise should be low impact, so we're not talking about running or heavy weightlifting or deep knee bends or squats. Just a half-hour walk each day has been shown to slow down the progression of osteoarthritis of the knee. Of course, if a person's joints are already painful, then weight-bearing exercise of any type may be difficult, but there are some options. Tai Chi is a great exercise for patients with osteoarthritis, and there are classes available for that or online instructions. And then water-based exercises in a heated pool of water. In the pre-COVID era, that was, of course, widely accessible, but with proper social distancing, nowadays might still be available. So water-based exercises or riding a stationary bike are options if your joints are too painful to go for a walk. Moving on to options for the use of medications in treating osteoarthritis, we have a whole range of treatments available. So starting from the simplest would be a topical anti-inflammatory gel, which is shown here on the left side of the slide. In the US, the only formulation that's available is diclofenac gel. It contains an anti-inflammatory compound. It's also available in an oral form, but I've just shown you the example of the topical gel. And this can be applied up to 4 times a day to the painful areas. It's particularly helpful for patients who have arthritis at the base of their thumb joints, but can be used elsewhere as well. And it's fairly non-toxic and well tolerated. You know, some people sometimes can get an occasional rash. The amount that's absorbed into the circulation is minimal. So that's a good initial option for many patients. If a topical anti-inflammatory pain gel does not work, then we can use oral tablets of anti-inflammatories. These are drugs that are described as NSAIDs, which means non-steroidal anti-inflammatory drug. And they're familiar to all of us. It includes compounds such as ibuprofen or naproxen, which is shown in this slide, different brand names, Motrin, Aleve, etc., and then their prescription equivalents. So these medications are widely used, including self-medication and over-the-counter treatment, as well as prescription treatment. They have been shown to be effective in relieving the pain of osteoarthritis. There are some side effects, so they're not suitable for patients with certain conditions, for example, stomach ulcers, high blood pressure, congestive heart failure, or patients who have kidney disease. Should avoid non-steroidal anti-inflammatory drugs. More recently, some information is available that raises a concern about the cardiovascular side effects of these drugs in terms of increasing the risk of strokes and heart attacks. So therefore, if a patient has risk factors for a heart attack or a stroke, a non-steroidal anti-inflammatory drug is probably not a good initial choice of treatment for those patients. And if these drugs are prescribed to those patients, then appropriate precautions have to be undertaken. Another option for treating pain is acetaminophen, also known as Tylenol. It may not be as effective as an NSAID for some patients. Therefore, it's a secondary choice of treatment. However, if a patient has medical problems such as stomach ulcers or high blood pressure, using acetaminophen would be a better choice for such a patient. Acetaminophen does not irritate the stomach or cause side effects on the kidneys. And if the recommended dose is not exceeded, it is safe. The highest dose of acetaminophen is 4,000 milligrams a day, which is taken in divided doses. So for example, extra strength acetaminophen 500 milligram can be taken at a dose of 1 to 2 tablets every 6 hours. One particular situation where acetaminophen should be avoided is patients who have liver disease, because it can be toxic to the liver. And for some patients, a combination of both a non-steroidal and acetaminophen can be taken safely in order to control the pain of osteoarthritis. In the past, we also prescribed what are called narcotic analgesics. Those are painkillers, for example, hydrocodone and oxycodone. Perhaps there was an overprescription of these drugs, and we know the consequences, the opioid epidemic with all its attendant bad outcomes. Because of those concerns, there has been a decline amongst rheumatologists in prescribing opioids. However, for some patients for whom acetaminophen or nonsteroidals either don't work or they are contraindicated, certain types of painkillers are available. The one that's recommended by the American College of Rheumatology is a drug called tramadol, a brand name of Ultram. This drug acts by binding to pain receptors in the brain and spinal cord. Those are receptors that are different from the ones that the opioid drugs bind to. So perhaps it might be less addictive, although that side effect is still present. It can create sedation and sleepiness, dizziness and nausea are some other side effects. And in terms of medications, there is a class of drugs which are called ancillary medications, which means they complement the effects of other treatments. One particular type of drug that's used as an ancillary therapy for chronic pain and osteoarthritis are antidepressants. And the one that's illustrated on this particular slide is an agent called duloxetine. Originally developed as an antidepressant, but it's also FDA approved for use in reducing the intensity of pain for patients with osteoarthritis. It has its own side effects such as sleepiness and imbalance and weight gain, etc. So patients have to be monitored for those side effects while they're being treated. In certain patients, if medications and physical therapy have not relieved the pain, we perform injections into the joints. And an example of an injection is illustrated here, where the needle is being inserted into the basal joint of the thumb. And it contains a mixture of local anesthetic, lidocaine or novocaine, and a steroid. Injections are effective in relieving the pain of osteoarthritis. Of course, it is a little painful to receive the injection itself, but if administered with proper anesthesia and technique, they are well tolerated by most patients. Theoretically, injections can be associated with complications such as bleeding into the joint or infection or damage to the underlying cartilage or bone. And in order to minimize those side effects, it is recommended that a particular joint not be injected more than once every 3 months. And if one stays within the recommended limits, the risk of long-term complications from joint injections is low, about 1 in 50,000. And finally, if all conservative treatment fails to relieve the symptoms, surgery is available as an option to relieve the pain of osteoarthritis. An example illustrated here is joint replacement surgery, where the knee joint has been replaced. And in appropriately selected patients, the outcomes of joint replacement surgery are very good, and in fact can be life-altering for many patients. Of course, it involves undergoing anesthesia and then a period of rehabilitation, but for many patients, the outcomes are very worthwhile, the operation. In addition to joint replacement, there are other surgical procedures such as removal of osteophytes and bone spurs or fusion of the joints, which can give lasting pain relief. So in conclusion, osteoarthritis is a common condition that can cause pain in the hands, the neck, the lower back, the hips, and the knees and the feet. It is diagnosed based on a patient's symptoms, findings on examination of the joints and x-rays, regular low-impact exercise, weight loss, the use of assistive devices and orthotics such as shoe inserts are an important part of the treatment. And medical management, including the use of medications, injections, and joint surgery can provide relief to many patients. Thank you for attending this webinar, and I'll be happy to answer any questions from the audience.
Thank you, Dr. Ahmed. And if anybody is interested in submitting a question, you can use the Q&A feature at the bottom of your screen, and you can enter your question there, and we'll have Dr. Ahmed answer those. I don't see any questions. We'll give it another minute. Here's one question. Do you recommend CBD creams at all?
Some patients do report relief from the use of CBD creams. I suggest to my patients that they can try it. And if they find benefit from it, it can certainly be continued. It is one of the treatments that has not been studied in rigorous control trials, so there isn't any evidence-based recommendation as far as the use, but anecdotally and from reports of patient experiences, it does sometimes work. So I do tell my patients if they're interested in trying it, they can do so.
What do you think about yoga for osteoarthritis?
Yoga is one of the low-impact exercises that are very helpful and beneficial for patients with osteoarthritis, and so I highly recommend it. And even though you as a person may not be somebody who's had experience with yoga, with a trainer or with online classes, people at all stages of life and osteoarthritis can benefit from it. So it is recommended as one of the types of exercises that are beneficial for osteoarthritis.
What about Fosamax? How long can it be taken?
Fosamax is a medication for a condition called osteoporosis. So it is often confused with osteoarthritis, but that's a natural confusion because both drugs sound the same. So just to be clear, Fosamax is not a treatment for osteoarthritis, it is a treatment for osteoporosis. So what is osteoporosis? Osteoporosis is thinning of the bones and fragility of the bones. So as a person grows older, and particularly in females after going through menopause, the levels of estrogen hormone decline, which is beneficial for the bones. Estrogen is important in bone health. And as the level of estrogen declines, or certain other medical conditions can set in that can weaken the bones and make them more prone to fractures. So Fosamax, which is also known as alendronate, and other drugs in the same class, work by slowing down the resorption of the bone. It slows down the activity of the so-called bone-eating cells, which are osteoclasts, which allows the body to lay down new layers of bone and strengthens the bone and thereby reduces the risk of a fracture. So it is an effective treatment for people who have been diagnosed with osteoporosis, especially if they've had what are called fragility fractures, which is breaking a bone from a low impact injury.
How effective are hyaluronic acid injections in the knees?
That's an interesting question. Uh, Hyaluronic acid is a synthetic compound meant to replace the natural hyaluronic acid, which is a component of the synovial fluid that we saw in the illustration of the joint. During the onset of osteoarthritis, the cartilage becomes damaged, and hyaluronic acid or hyalgan provides extra lubrication, and the body cannot produce enough of it to meet the needs for lubrication. So the theory behind hyaluronic acid is based on trying to improve the lubrication within the joint. And because of that theory, a compound has been developed. It is an injectable form of hyaluronic acid, which comes in a gel, and it's approved for use in osteoarthritis of the knee. Initially, there was a great enthusiasm for this treatment, but later on, through observational studies, it appears that the effectiveness may not be as high as initially thought. There's a difference of opinion in the effectiveness of hyaluronic injections within the knee joint between rheumatologists and orthopedic surgeons, but within the rheumatology community, its use has declined because of less effectiveness as compared to placebo. However, it is still an appropriate treatment for certain patients, for example, those who cannot undergo surgery because they may be too frail for undergoing anesthesia, etc. In those patients, an injection of hyaluronic acid within the joint, if it works, can provide pain relief for up to 6 months.
Are there specific inflammatory foods that should be avoided?
Yes, generally speaking, anything that's not good for your heart and your cholesterol is likely not good for arthritis and inflammation. So, for example, refined or processed carbohydrates, which means sugar, white bread, white rice, fried foods, foods that are rich in cholesterol, anything that you can eat out of a bag. Those are things that are bad for arthritis, they're bad for inflammation, they're bad for your cholesterol and blood pressure, etc. What are some healthy foods? It includes plenty of fresh fruits and vegetables, legumes, and whole grains, more proteins as compared to carbohydrates is an effective diet for people with arthritis.
My knees have reduced cartilage, not painful yet, but they are a bit unstable and crunch, pop sometimes. Will exercise help?
Definitely. So exercise is a cornerstone of both preventing and treating osteoarthritis, and muscle strengthening. If there's arthritis in the knee, quadriceps strengthening exercises, walking, riding a stationary bike, swimming, water-based exercise, anything that a patient can reasonably do, does not matter what type of exercise, is beneficial for arthritis and crunching and grinding of the joints.
I have arthritis in my right hip. A steroid injection and physical therapy did not help. My physician said I have very mild arthritis. What do you recommend I try next? Would a second steroid injection help?
It may be worthwhile trying a second steroid injection, and there are two types. So talking about arthritis of the hip, there are two types of injections. Some people have pain on the outside of the hip joint. That pain is due to a condition called trochanteric bursitis. And it's treated by a steroid injection that's given in the doctor's office. Many people have arthritis within the hip joint, and that causes pain typically felt in the groin area. Because the hip is a deep joint, injections within the true hip joint are given under X-ray or fluoroscopy. So I'm assuming that your injection was within the true hip joint, which is given under X-ray guidance. Now, it may be that the needle or the placement of the medication might not have been exactly within the joint space, and perhaps that might account for a lack of relief. So it may be reasonable, 3 months after the initial injection to try a second injection. However, if even a second injection does not work, then your choice of treatment depends on how painful the condition is and how limiting and how disabling it is. Now, you had mentioned that your doctor said you have mild osteoarthritis, and I'm assuming that they're basing that on the findings in the X-ray. Now, it turns out that for some patients, the findings on the X-ray do not correlate with the level of symptoms that they have. In other words, the X-rays may show mild osteoarthritis, like a stage 2 in the slides we looked at, yet your pain might be very high at level of 10 or higher. So your treatment decisions are at that point based on not solely on what your X-rays show, but how bad your symptoms are. And if a steroid injection and medications have not relieved the pain, regardless of how bad it looks on the X-rays, you may want to consider consultation with an orthopedic specialist to discuss whether it would be suitable for you to undergo hip replacement surgery.
Hello, Dr. Ahmed. I have osteoarthritis throughout my spine. I have had 2 failed surgeries, epidurals, burning nerves, etc., in the sense that I still have pain. I also have numbness in my right hip and a lot of pain in my legs, knots in the legs. Is there anything else to try?
So chronic back pain can be a challenging condition to treat. And unfortunately, there hasn't been any treatment shown to provide long-term relief. Having said that, there are ways that the pain can be made more bearable and functioning can be improved. And I have to emphasize that a large part of that is non-medication based approaches, particularly stretching and exercise. Even if you can do a little bit of that, initially may create a little increase in the pain, but if you persevere over a period of 4 to 6 weeks, you may find that the pain diminishes. Pain management specialists can also be helpful. So people can get scarring after an operation, which can lead to chronic back pain after surgery. Procedures such as epidural injections or nerve blocks sometimes can provide temporary relief. If you have chronic back pain, I assume you've gone through the ancillary treatments, but depending on your medical history, medications such as duloxetine and gabapentin and other agents in the same class might provide some benefit for the chronic pain. Sometimes the source of pain is in the muscles rather than the vertebrae or the spine. And in that case, a soft tissue muscle trigger point injection with Novocaine and cortisone may be able to provide some temporary relief. And I don't know if you've tried it, but there is a topical anesthetic patch. It's a lidocaine patch. The brand name is Lidoderm. Although it's not FDA approved for people with chronic back pain, some patients do find benefit from using it. So if it hasn't been tried, that might be an option that you could discuss with your treating physician.
Thank you. You haven't mentioned osteoarthritis of the shoulder.
Yes, indeed. So osteoarthritis can occur in the shoulder joint. Usually, osteoarthritis by itself does not present with pain in the shoulder joint. Usually, it is the result of either mechanical damage to the joint, repetitive arm motion. So, for example, we all know the incidents of baseball players who get arthritis in the shoulder from wear and tear. But patients who are not professional athletes can get it if, for example, they've had injuries or tears to the rotator cuff. That can lead to what's called secondary osteoarthritis in the shoulder joint. Another smaller joint, which is not true part of the shoulder but is outside the shoulder, however, can create pain in the shoulder, is called the acromioclavicular joint, which connects the clavicle, the collarbone, to the scapula, which is the shoulder wing bone. That can be another source of pain. For patients with osteoarthritis of the shoulder, the treatment is similar to arthritis elsewhere, which is moist heat, heating pad, topical non-steroidal cream, oral non-steroidal medications or acetaminophen and joint injections. If those are all ineffective, then shoulder replacement surgery can provide relief.
The same person had followed up and said the pain radiates down their arm and wanted to know what could help.
The pain radiating down to the arm makes me wonder if it is indeed coming from the shoulder joint, because that might be what's called referred pain. That can arise due to problems in the cervical spine, which is the spine in your neck area. There may be issues such as degenerative disc or arthritis in the cervical spine or bone spurs. Those can press on the nerves that supply sensation to the shoulder and the arm. So it may be worthwhile having that looked at. A neurologist can certainly examine you and determine if the issue is coming from the cervical spine, and if so, that can be addressed appropriately.
Thank you. Does rain and humid weather affect osteoarthritis?
Absolutely. It's not an old wives' tale. It is indeed true. And many of my arthritis patients tell me that they're like the weathermen, and they're correct. Humidity and rain, cold weather generally makes the pain of osteoarthritis worse. Why that happens is unclear. One explanation, which is as good as any other, is that when there is rain or humidity, the barometric pressure, the atmospheric pressure drops. Your joints themselves have an internal pressure which keeps the joint space open, and when there's low barometric pressure, the pressure inside the joints increases, so it makes them hurt more. But certainly it's very true that weather plays a role in the symptoms and can make it feel worse.
Are citrus nightshade vegetables harmful?
That is, excuse me, that is reported more on an anecdotal basis. So if you look at large-scale epidemiologic studies, those are a little challenging to do in terms of controlling what participants in the study are eating. There is no evidence-based recommendation to say that those medications are harmful. So if it is something that you enjoy eating, I would not stop you from doing so, because there's just not enough evidence to say that there's any harm in them. Now, the human body is an amazing creation. And science is not all-knowing. So if in your particular case you find that your symptoms worsen after consumption of such vegetables, by all means you can avoid those. But if we're talking about a general recommendation, there's no harm in consuming such vegetables.
Do rheumatologists administer the injections you're discussing, or orthopedists?
Both. Steroid or glucocorticoid or cortisone shots, as they're commonly known, they can be administered by rheumatologists, they can be administered by orthopedic surgeons, and in fact, some primary care doctors who have an interest in treating arthritis are also trained. So if your primary care physician has experience and comfort with doing it, they can also administer those kinds of injections. But typically, those are performed by rheumatologists and orthopedic surgeons.
What is the difference between arthritis and rheumatoid arthritis?
Arthritis is a broad term, so it encompasses many conditions. And when we talk about arthritis, what we mean most often is osteoarthritis, which is the topic of this webinar. However, there are at least a dozen other types of arthritis, one of which is rheumatoid arthritis. And the difference is that whereas osteoarthritis is a process of wear and tear and mechanical stress on the joints, rheumatoid arthritis is a process of inflammation. And inflammation is a condition where the body produces some proteins and enzymes that can attack the lining of the joints, and they can cause swelling, a lot more stiffness than we see in osteoarthritis. It particularly affects the small joints, the knuckle joints in the hands, the wrists, the ankles, and the feet. And rheumatoid arthritis can be a more rapidly progressive disease as compared to osteoarthritis. It can damage the joints faster than osteoarthritis. The causes of rheumatoid arthritis are different. It may be, in large part, a genetic disease, and it involves overactivity of the immune system. So the treatment is quite different from osteoarthritis. The treatment of rheumatoid arthritis involves typically steroids and what are called immunosuppressive drugs that work by lowering the overactivity of the immune system in order to prevent it from attacking and damaging the joints.
I had a foot operation that was extensive. Will this make me more prone to arthritis in my foot?
That is difficult to say. It's difficult to predict the outcomes for an individual patient. But generally speaking, having joint surgery is meant to reduce arthritis. So therefore, the risk of getting osteoarthritis after foot surgery is low.
What is your opinion on injections for osteoporosis?
Talking about a different condition, just for the information of the audience. So we are moving for this question from osteoarthritis back into osteoporosis, which is thinning of the bones. And there are injectable medications available for patients with osteoporosis, which is thinning of the bones. Currently, there are two types of injectable therapies. One is what's called a monoclonal antibody. It is called denosumab. And there are a couple of other drugs in the similar class that are now available. Denosumab and drugs like it act by inhibiting the activity of osteoclasts, which are the bone-eating cells. It's given as an injection into the skin once every 3 months, and its effect is to strengthen the bones and reduce the risk of fractures. For osteoporosis, or thinning of the bones, another injectable therapy is available, which is called teriparatide. That's a synthetic hormone that promotes the activity of the bone-forming cells or osteoblasts. And a couple of drugs are available that are in the same class as teriparatide. For example, there's a drug with the brand name of Forteo that's given as a daily injection administered by the patient into the skin. And its actions also is to strengthen the bones and reduce the risk of a fracture. And these therapies are effective in strengthening the bones.
And we have time for just one last question. If anybody did not get their question answered, you can email us at matherhospital@northwell.edu, and we'll be sure to follow up with Dr. Ahmed for further information. The last question I'm going to ask you, Dr. Ahmed, is will joint replacement on the knee slow any spread of arthritis in the joint?
Joint replacement surgery addresses only the joint that's involved with osteoarthritis. So unfortunately, it does not work at other joints. There may be some indirect benefit to the other joints. So if, for example, a person has arthritis in the right knee, their left knee takes up more burden of walking. And if you get the right knee replaced, there is less pressure on the left knee because now you can bear weight equally and normally. So if that is indeed your question, then yes, having joint replacement on one side may be good for your normal joint on the other side, but it won't prevent you from getting arthritis in a totally different area of the body. So for example, getting a hip joint replaced wouldn't prevent arthritis in the shoulder joint or the hand joint. And hopefully that answers your question.
Thank you. And thank you for taking the time to educate us about osteoarthritis and answer all these questions in depth. It's so helpful. Thank you everyone for joining us today. We apologize for the late start. This is the first webinar we're doing in a series. We will be running these every Tuesday at noon, different topics. You can keep an eye on your email. And there will be a survey when this webinar ends that we'd like you to complete. Your feedback is extremely important to us. Thank you, Dr. Ahmed, so much. And thank you, everybody, for attending.
Thank you.